Good morning, all. Uh, my today's topic is bronchial asthma management beyond inhaler therapy. Particularly, I am targeting allergen-specific immunotherapy. I think many of you doctors never heard these terms. What is allergen-specific immunotherapy, right? Am I right? Right. So, let's overview of my lecture is bronchial asthma basic. We will not go in detail as already Tushar bhai has explained its main treatment, definition and rationale of immunotherapy, types of immunotherapy, immunological mechanism, clinical indication and contraindication, and safety and future directions. So we'll look પહેલી વાર આપણે immunotherapy શું છે, right? Immunotherapy, why? Actually, it is started in 1911 by Leonard Noon, first time. But today is 2025 and still immunotherapy is in its crawling phase. It's in preschool phase, we can say. કેમ હજી સુધી એટલું એનું એડવાન્સમેન્ટ નથી એવું, એનું એક્સેપ્ટન્સ નથી એવું, અને ખાસ કરીને ઇન્ટરનેશનલ બોડીઝ છે અને જેમ કે જીના છે એને જીના હેઝ ફર્સ્ટ ટાઈમ એપ્રુવડ ઇટ્સ ટ્રીટમેન્ટ ઇન 2017 ઓનલી, and it's only for house dust mites, right? We can detect almost 150 allergens, food plus aero allergen, but still Jina has given only permission to use house dust mites only, and many bodies like FDA and American bodies still not approved it, because look, there are hurdles why we cannot use it. Still we cannot use it because of its purification. We cannot purify exact protein responsible for allergy. So what is asthma? Asthma is chronic inflammatory disorder of the airway characterized by bronchial hyperresponsiveness and variable airflow obstruction. Definition is very important to diagnose asthma. Asthma is a serious global health problem. Almost 30 crore people of the world are suffering from asthma, and this is only for asthma, not other allergic diseases. And most common allergic disease is not asthma again, it's allergic rhinitis. It's way more common, almost 2 times more common. So we can say 50 to 60 crore population peoples in the world's population are suffering from allergic rhinitis. And with higher morbidity and mortality is seen in lower socio-economic class, particularly in developing country of Southeast Asia and Africa. So phenotype is very important. Look, phenotype of asthma is important to proper treat it. What to give, when to give, right? When to give inhalers, when to give immunotherapy, when to give long-term azithromycin. So phenotype is main is allergic versus non-allergic is the main phenotype. All other are its subtype, like adult versus early onset. Adult onset are mostly non-allergic, early onset are mostly allergic, drug induced are allergic, eosinophilic versus neutrophilic, like this. Now diagnosis will going briefly. Look, asthma diagnosis main part is clinical history and history. No any PFT, no blood investigation can replace it. Without history, it's all useless. Second is physical examination. PFT and PFR already explained in previous lecture. Type 2 biomarkers like fractional exhale nitric oxide, IgE level, blood eosinophil count, tissue eosinophilia, we can do it. And last and main part for immunotherapy is allergy test for sensitization to specific allergen by skin prick test or blood test. Treatment part, I will say only one thing. Since last few years, Jina also removed, avoid SABA as a reliever therapy in asthma. Always use low dose ICS with LABA, particularly formoterol, because it has early onset of action. So always use ICS plus LABA as and when required also. And last, yes, exercise and nutrition is also very much important, has important part in its treatment. Look, we can treat almost 90 to 95% of asthma patient very well with only inhaler. But what for remaining 5 to 10% of asthma patient, which falls in category of difficult to treat category, because it remains uncontrolled despite moderate to high dose of ICS with LABA combination. So first of all પહેલા તો આપણે જોવું પડે કે ખરેખર આપણે અસ્થમાને ટ્રીટ કરીએ છીએ, ખરેખર પેશન્ટને અસ્થમા જ છે કે our diagnosis is incorrect. There are many asthma mimics like ABPA, allergic bronchopulmonary aspergillosis, are very common. COPD, vocal cord dysfunction, it's actually psychiatric problem. Upper airway obstruction which needs intervention. Endobronchial infection which needs proper diagnosis and treatment, like endobronchial tuberculosis, are very common. Even many vasculitic patients come with stenosis of trachea or main bronchus, which initially mistreated as asthma. Second is very common in our community, incorrect inhaler technique and poor adherence to medication. Because of many myths, many patients want to avoid inhaler treatment and they just take injection or oral steroid when he develops exacerbation. Otherwise he accepts it's asthma. Third most common part is comorbidity. Look, when patients remain untreated for chronic rhinosinusitis, asthma will never going to control. Even with higher dose steroid, that patients may require repeated course of oral systemic corticosteroid. So we have to diagnose allergic rhinitis, nasal polyposis. He may need surgery. Chronic rhinosinusitis, GRD, obesity and sleep apnea, these all are associated comorbid condition which leads to difficult to treat asthma. And last and most common part, triggers, particularly in occupational exposure. We have to detect by proper history tracking only. Now for that, immunotherapy. What is immunotherapy? First, it's all method to overcome abnormal immune responses with induction of clonal deletion, energy, immune tolerance or immune deviation. It's very well used nowadays in by oncophysicians for many malignancy, but still it's very less used in allergic diseases. It is we can divide it in two parts. Specific means allergen specific immunotherapy, which we are going to discuss in detail. Second is non-specific, also known as biologics. Currently in India, we have 3 biologics available. One is anti-IgE omalizumab. Second two is anti-IL-5, which acts on eosinophil, mepolizumab and benralizumab. It is actually very effective if patient selection is proper. The only problem is its cost. It costs 25 to 30,000 per month, and you have to continue it for maybe lifetime. So most of the patient denied since beginning, and they are happy to take low dose steroid. And second is allergen specific immunotherapy, also known as desensitization. This is the only available treatment which modify natural course of allergic diseases, and it can halt its progression. So, and its effect even last longer even after stopping the treatment. Now history, it is first time introduced by Leonard Noon in 1911, and it is SCIT by SCIT. So SCIT was introduced in 1911 by Leonard Noon, and then after no any further any development in immunotherapy chapter. Then first time between mid 20th century, there are first randomized control trial for allergic rhinitis and insect venom allergy. And the SLEET was introduced first time in between 1980s to 1990. So SCIT was introduced in 1911, and first time SLEET means sublingual immunotherapy, which is easier to take. SCIT means subcutaneous immunotherapy, which is actually difficult. Why it is difficult, I will explain later on. And after 2000, there are many development in immunotherapy. particularly molecular allergology and component resolve diagnostic. And HDM slit was first time integrated in GINA guideline as an add-on therapy, not primary therapy, as an add-on therapy in 2017. Future frontier means there are many studies ongoing in phase 1 trial of combining AIT with monoclonal antibodies, recombinant vaccines using genetically engineered hypoallergic variant to target specific T or B cell pathway. These are on phase 1 trial only. Look, what we need to give immunotherapy. First of all, we have to identify exact allergen responsible for patient's symptom. So we have right now two type of test. One is in vivo, is skin prick test. Second is in vitro blood test. Skin prick test is still remain gold standard screening test in allergy practice because it is very cheap. It can be done in doctor's room, office, and readily available, and its result will come in 30 to 40 minutes only. Second most common used test is immunocap by Fadiatop. Please avoid ELISA test, which are done by many labs. These are non-specific. There are no non-sensitive or no specificity. I will not take name of laboratories, but they are doing very cheaply. I think 2500. They do 150 to 170 allergens. There are no meaning. We cannot do anything based on this test. So we have to rely on only skin prick test or blood test by immunocap method, which are again very costly test. It is costing 1500 rupees per single allergen, or we can do bunch of tests like 5 allergen or 10 allergen. It's costing almost 5,000 to 7,000 rupees. And CRD actually component resolve diagnostic is very advanced test which comes recently, that identifies specific protein molecule within allergen and help to differentiate true allergy from cross reactivity. Look, we have to understand skin prick test and immunocap test didn't directly detect allergy. It just detects sensitization, and sensitization and true allergy are very different thing. But CRD can diagnose direct allergy. Look, I will give you one example, right? Food allergy is very rare in India. Aeroallergen, particularly dust mite allergy, is very, very common in India. So what is dust mite? Dust mite is very tiny insects. They are made up of thousands of lakhs of proteins. Its bodies are made from, I think, lakhs of proteins. Out of these lakhs of proteins, very few proteins responsible for developing allergies, like DRP1, DRP2, DRF1, DRF2. These are the proteins we can diagnose, we can detect by CRD, but we cannot detect by SPT or immunocap. Immunocap just shows sensitization. Even normal patient can shows positivity to that test. So what we can do skin prick test as a screening test. Then further, if it comes positive for few allergen like peanut allergen or dust mite allergen or specific pollen allergen, and if patient symptoms correlate with that particularly, we can further do CRD. CRD tests are actually costly test. I think 15 to 20,000. Since last few years, it is costing more than 60,000 before few years. And last is very important, which is not done in India. Actually, it is allergen challenge test. It is what we will do in this test. We'll do controlled exposure of the suspected allergen in the medical environment. There are exactly lab, like glass lab. Some Western worlds are only doing this, and it is also for research purpose, not for as a diagnostic purpose. Still is on research phase because it is actually hazardous test, because patient may develop severe asthma exacerbation or even anaphylaxis during this test. So we can do main two tests, skin prick test, and second is blood test by immunocap or CRD. Both have its own advantage and disadvantage. Skin prick test is main advantage is it is cheap, readily available, highly sensitive, right? second, very cheap and mostly no any contraindication, very less expensive. While blood test is slightly costly, it will available within few days. The main advantage of blood test is it can be done in some patients which cannot stop antihistamines. We have to stop antihistamines if we want to do skin prick test for 5 to 7 days. And many skin conditions like dermatographism, severe eczema, we cannot perform skin prick test. But in all these conditions, we can do allergy blood test. So, which allergens we can detect by this test? Food allergen, very rare in India. And look, we અમે ઘણા બધા પેશન્ટમાં કરતા હોઈએ છીએ કેમ કે they wants to do it, right? મોટા ભાગના પેશન્ટ તમને એક જ ક્વેશ્ચન પૂછે, સાહેબ અસ્થમામાં અમને આ શ્વાસની તકલીફ છે, શું ખાવાથી થતું હશે? બરાબર, મારો એક જ જવાબ હોય છે કે આ ખાવાથી થતું જ નથી. ઇન્ડિયામાં બહુ almost 2% asthmatic are due to food allergen. While that scenario is different in Western world. Western world ma food allergy are very common. Here we have aero allergy are very common, right? Food allergen ma je positive આવે છે that is due to because of cross reactivity, also known as food allergen syndrome. મેં કીધું ને કે sensitization and true allergy are different thing, and skin prick test and immunocap એ differentiate કરી શકતું નથી. That's why many patients shows positivity to many food allergy, food component, but that is not true allergy, right? So this test is not as simple કે ભાઈ આ પોઝિટિવ આવ્યું તો આ પોઝિટિવ છે, આ નેગેટિવ આવ્યું તો આ નેગેટિવ છે. એવી રીતે અમે ઇન્ટરપ્રિટ કરી ના શકીએ સ્કિન એલર્જી કે ઇમ્યુનોકેપ ટેસ્ટને. We have to correlate with clinical symptoms. One is food, second is house dust mites, particularly dermatophagoid farini and dermatophagoid terinosinus and Blomia tropicalis. These three are very common. Third, pollen. Many grass, weed and tree pollens are responsible for symptoms, particularly seasonal asthma. Look, this is the season, right? We will see two season, main two season in March, April and November, December. કે જેમાં જેને આખું વર્ષ સારું રહે છે પણ આ જ ટાઈમમાં એને સિમ્પટમ્સ આવે છે. they are mostly allergic to pollens. Fourth is fungal, insect and animal denders. Allergen are non-harmful. Look, normal individual actually allergen થી રિસ્પોન્ડ જ ના કરે, અથવા તો કરે તો એ TH1 ટાઈપ 1 ઇમ્યુન સિસ્ટમ થી કરે. જ્યારે એટોપિક ઇન્ડિવિજ્યુઅલ છે TH2 T હેલ્પર 2 સેલ્સ રિસ્પોન્સ કરે છે, એ IL4 સાઇટોકાઇન રિલીઝ કરે છે અને એના લીધે ઇમ્યુનોગ્લોબ્યુલિન ઈ પ્રોડક્શન થાય છે ને કે જે માસ્ટ સેલ અને ઇઓસિનોફિલ હાર્વેસ્ટ કરે છે ટિશ્યુમાં, અને these are the responsible for their symptoms. So what are the possible mechanism of action is that if you give allergen exposure in controlled dose, it will decrease TH2 cytokines, it increase regulatory T cell, which in turn increase TH1 cytokines and decrease IgE production and increase IgG blocking, also known as blocking antibody, and ultimately it will develop patient will develop immune tolerance. What are the indication? All the allergic conditions we can give, in all allergic conditions we can give immunotherapy, including allergic rhinitis, conjunctivitis, asthma, anaphylactic reaction, atopic dermatitis or IG mediated food allergy. Contraindication, there are no absolute contraindication, only relative contraindication. If suspected clinical symptoms and exposure do not correlate with positivity of report. During acute exacerbation, look, if patient in uncontrolled asthma or exacerbation, don't start immunotherapy, because immunotherapy will going to worsen initially, in initial phase. Patient symptom will going to worse in initial 1 to 2 months. Active autoimmune disease or malignancy, that depends. What is patient's lifestyle, what is patient's lifespan. If there are many malignancy કે જેમાં પેશન્ટને ક્યોર રેટ સારો હોય છે, તો we can start simultaneously immunotherapy. Beta blocker therapy, these are very relative contraindication and poor patient compliance. There are very minimal side effect for sleet. Look, sleet is very safe actually, but slightly less effective, and subcutaneous immunotherapy are very effective, but it shows there are many systemic reactions like anaphylaxis or angioedema and exacerbation of underlying allergic disease. These are not actually adverse effect, these are good signs, because if patient's symptoms worsen initially, that means his immune system are responding to that allergen exposure. What are protocol? Look, desensitization is gradually exposing person to the increasing dose. For sleet, we have to give in higher concentration. So first dose is 1:500 dilution, second dose is 1:250 dilution, and third dose onward it is 150 dilution. Whereas for skeet, we have to give more dilution because it may shows more side effects. So 1:5000, 1:500, and 1:50. It should be given under observation. Its effect should be measured after 3 to 4 months, because initially patient symptoms are going to worse. We have to explain very well for this. And total duration, it should not be given below 3 years. We have to give, if patient shows response, we have to give it more than 3 years. Up to life we can give. Sleet is better. Why sleet is better? It is because it is safe, it is easy to administer, patient can take it at home, and there is no needle prick. Skeet, why when skeet is better? When there are multiple allergy. Look, in India, most of the patients shows polysensitization. Means patient, if he sees there are 15 to 20 positive, significant positive allergy, at that time we have to choose 3 to 4 allergy, and for 3 to 4 skeet is better than sleet because that concentration and efficacy. So my key takeaway that allergen immunotherapy is the only disease modifying treatment. Look, inhaler can just control your asthma, it cannot cure your asthma, but immunotherapy can. Strong role in respiratory allergy. It requires careful patient selection, because patient selection is very important, and long-term benefits beyond symptom control. It didn't just control symptom, it control in even eradicate disease. Thank you.